Welcome to Early Detect Studios. I'm Sheena Gill, President and CEO Americas for CognitiveCare, and we are absolutely delighted to have Dr. Jasleen Pannu, an experienced pulmonary and critical care physician specializing in interventional pulmonology. She is currently Assistant Professor, Director of Interventional Pulmonary Translational Research with the Ohio State University Wexner Medical Center, where she is leading the very exciting Early Lung Cancer Detection Program. She earned her medical degree from Goa Medical College, completed her residency at Western Reserve Care System in Youngstown, Ohio, and completed fellowships in her field with Vanderbilt, the Mayo Clinic, and Bridgeport Hospital. Jasleen, I'm so thrilled to have you here because you're such an inspiring physician. Your passion for not only interventional pulmonology, but for using every innovation available to achieve early detection of lung cancer is so commendable. So let's get right to it.
Thank you so much, Sheena, for such a great introduction. It's always great to chat with you. So thank you so much for having me here.
Absolutely. So I've heard members of the field refer to you as an early lung cancer detection and prevention enthusiast. I just love that. And I'd love to learn more about your journey. So what inspired you to become a pulmonologist? And moreover, what inspired you to want to pursue in this field from the angle of early detection through innovation?
Actually, till about a few years back, I had no idea much about this field. And straight out of my residency, I wanted to do more ICU. And that's why I went to the Mayo Clinic to do my fellowship in critical care. And that's when I met the staff related to interventional pulmonology. And I was really attracted to that field. Interventional pulmonology, by default, deals with a lot of patients with lung cancer because it deals with doing lung biopsy and procedures of the lung. And a lot of time the patients that have these conditions have lung cancer. So that automatically brought me closer to working with patients with lung cancer. My journey with early lung cancer started when I actually started my job at Ohio State in 2018. Because I noticed here as I was a new attending that there were patients very young in age, 30s, 40s, that were presenting with late stage cancer. And sometimes I would see that they had had a prior image a few years earlier, and there was a sign of a small little spot, which was now a big mass, a big tumor, and it was missed, and nobody had done anything about it. And that was the most saddest feeling I could get because I felt that was a failure on our part as a system. And it almost like destiny brought the patient towards rescue, and we weren't able to catch it. And then I dug in deeper on how big is that problem, because usually we think that that must be a random, very rare case, and it shouldn't happen that much. And I realized actually that was happening in majority of cases. So national data said that that was happening in 70% of cases with accidental detections of small spots in the lung. And then we went ahead, did a study at Ohio State for the year 2018, and we found that more than 50% of such spots were not followed according to guidelines. And the volume of this problem just shocked me. And it also appeared as a great opportunity to prevent these things from happening and make a real stride in preventing late detections of lung cancer or missing detecting lung cancer. So that's what turned the corner for me towards early lung cancer detection.
That's very inspiring, and I think it's wonderful that you identified a problem where you can make a difference and you're marching right towards the solution. And, I think on a recent NBC channel, they showcased how you and your team have implemented this program to help detect the tiny lung spots or nodules and that might otherwise go undetected, I believe you're referring to. And I understand that with this program, your system alone has the potential to catch at least like 1,000 cancers early that otherwise wouldn't be detected yearly. Please tell us more about this program. I think our audience would be really inspired to learn more.
So while the idea was very intriguing of trying to put a program in place, it was really difficult because the volumes of these lung nodules are massive. So countrywide, 1.5 million incidental lung nodules are detected. At our center alone, 15,000 of lung nodules are detected. Some of them are already known and being followed, and patients have lung cancer, but about 10% or so would be incidental. And out of those, there's a variation of about 4 to 25% that would be malignant. So that's how this prediction comes from, so about say 10 to 25% of that volume, of 1,000 people that could have this new detection in that year. Our challenge was how to manage these large volumes, because this was not something that I thought that could be managed by just hiring 1 or 2 people, and they cannot be held on to just going through thousands of these scans a year, and then also coming up with a manual system to manage when they need a repeat scan. How do we know if they've had a scan somewhere else? How can we send them reminders? So it needed the assistance of automated management or AI or other forms of it. So that's where that existence came into being. And then it obviously cannot function by itself on autopilot. So it needs a staff that needs to go with it. So we spoke about having a dedicated staff. And then what happens when we make these detections? Do we just tell them and do nothing about it? So we had to open a specialized clinic for outflow, which needs to be specialized, because lung nodule management is not just about ordering CT scans for follow-up. It's a multidisciplinary management. Sometimes patient needs a surgery, sometimes they need a biopsy, sometimes they need a follow-up scan or other kind of scans. So it's a specialized management, and for that, multidisciplinary team was organized. And it was important to do that, and also fruitful, because we realized that a lot of people were thinking about the same problem, but also struggling with the idea of what to do about it. So thoracic surgery was thinking about this issue, and they have a lot of stake in it, because they are the ones operating on early lung cancer for its definitive treatment. Radiology was thinking very seriously about it. Emergency rooms were thinking, because they were dealing with liability of when they read a nodule and nothing is done about it, what falls onto them about doing something to treat this nodule. They were not sitting in clinics to treat patients, so they cannot really see the patient or advise anything, but they can just dictate a report. So there were so many people who were intricately connected, but I realized that there were attempts being made to try to come up with the system, but because of the sheer volume of these nodules, it was hard. So that's how we came through, or we dreamt this idea of a comprehensive multidisciplinary program that would operate on multiple levels, that would have some part of artificial intelligence, but also human intelligence and some dedicated specialties that would put in time to deal with this issue. And that's how it came to be.
Fabulous. And just as a follow-up there, when you say artificial intelligence, how exactly are you using AI? Is it NLP in this program? Do you mind elaborating there?
So the use of AI has to be very locally directed. So we are using natural language processing, because that was the most suitable to our local preferences. So we wanted to also, once we're initiating the program, we want to first catch the nodules that have already been detected and read, and we need to get them to get their treatment. Now, further steps in AI are also available, where in certain programs, AI is actually automatically detecting these nodules. And one has to deal with that workflow of what do you do with those detections? What if it's a very minor detection? Are we just increasing our volumes? Or are we really catching meaningful cases? So that's one aspect of things. AI can also help in risk prediction, because while there are thousands of these nodules, fortunately, 90% of them will be benign. So if we started biopsying and resecting every single nodule, then a lot of people would lose a lot of lung tissue, and that's not okay. So
Right.
a big part of decision making as a clinician goes into understanding which spot is benign, which is malignant, and which one you need to act on early, and which one you would rather just watch. So you're not doing unnecessary procedures. At the same time, we're not holding back when it's actually cancer. So a lot of uh, effort needs to be put into risk prediction by the clinician, and AI also helps in that now. So there are multiple facets of it. We are right now engaging in the natural language processing part of things, which filters these reports that have concerning detections. And then it is also somewhat organized in terms of urgency of addressing by the due date that we set. But then we have a coordinator and a navigator who looks at these findings daily and addresses urgency issues, contacts the patients, gets them scheduled, and they flow into a nodule clinic.
Wonderful, wonderful. It's so impressive. And I hope that your work is inspiring other organizations to emphasize early detection with as much passion and as much rigor as I see in you. In a talk that you gave recently, I heard you say that lung cancer is detected in these accidental findings at a rate like 4x than as compared to normal screenings. And that was really shocking to me. Why do you think that is? And do you believe these are systemic issues or issues, systems issues? Or what do you think is causing this?
That's a very important question you ask. And, I was really recently thinking about it, and I realized that we should not be detecting cancer accidentally. We should not be relying on destiny for us to come across cancer. We should be intentionally looking for early lung cancer, just like we look for cervical cancer, mammograms, for breast cancer, and several other programs. And actually, there is a program for lung cancer screening where we intentionally look for lung cancer in patients with a high risk of having lung cancer, the patients who have smoked for a long period of time or had a family history of such cancers. However, the implementation rates of this program are very, very low. They're as low as less than 10% of patients who should be getting these scans get these scans. More than 90% of patients who are eligible actually don't end up getting these scans,
Wow.
which is a difficult problem, and it's a multifaceted problem. So this is as compared to breast cancer, cervical cancer, this is a newer screening guideline. There's issue about volume of how to implement this. Not every state will cover these scans. There is an internal stigma attached to getting these scans with patients, which is extremely important. And the stigma is bilateral. The stigma is in healthcare providers as well as with the patient. And the stigma is really that every time, and I've noticed that when a patient is told that they have lung cancer, they almost immediately give an excuse of guilt, saying that, I smoked. So or they feel shocked, like I didn't smoke. So you don't see a patient who you tell you have cervical cancer or breast cancer, they don't automatically take responsibility of having it. They don't say like, oh, I got cervical cancer because I did this. No. So there's a lot of guilt that patients carry. And just like, I draw this analogy, sometimes we keep delaying an appointment with the doctor because we know something may be wrong, or we're feeling bad about something we did. Like we keep delaying a dentist appointment because we know there may be a cavity, or yeah, this tooth is hurting, I know there must be something wrong. The same way, there's a lot of avoidance of this issue from the patient perspective, because there's fear and there's lack of empathy they feel even from their own selves towards themselves, because they instantly try to blame it. And then same around everybody. The moment somebody has a nodule, the next question we ask, have you smoked? Or how long have you smoked in your life? So that automatically brings a responsibility that because of your action, this happened. So that's a very important part, which is subconsciously happening, which I think avoids patients from being openly talking to their physicians. Funding is a big issue because lung cancer is the most common cancer that causes mortality, more than colon, breast, and prostate cancer combined. So it's causing more deaths, but it has the least funding right now to implement such programs for coverage of these tests. So I think there is a lag in what we know as compared to what's being implemented. But I think better times are coming. I think awareness is increasing. There are several projects, the White Ribbon Project, GO2 Foundation, Longevity Foundation, which dedicates its mission towards trying to promote early detection of lung cancer. So I think good things are coming, but the state right now, we have a lot more to do.
Understood. And I think this goes along with, I recently heard that you've called for lung cancer screening for at-risk populations to be more generalized. So do you mind just expanding a little bit about that and what additional type of research would be needed to actually make that happen?
Yes. So lung cancer doesn't only just happen in patients who have smoked. 20% of lung cancer is happening in patients who have never smoked. And more than that, say 40% or so may be happening in patients who actually don't meet criteria for screening. So these
Mhm.
are the patients that don't even meet the requirements that would get them to a CT scan for looking for cancer. And more studies are coming actually from Asia. There was a study from Taiwan which studied women that were non-smokers and the incidence of cancer in them and what could screening do for these patients. So maybe in a few years, we may be looking at that everybody requires a screening for lung cancer. And that brings us to an important question that are we going to scan everybody? Is everybody going to get a yearly CT scan, and how feasible is that? And
Mhm.
that's where research comes in. There's research happening and more discovery happening on trying to find an alternative test as compared to a CT scan. Maybe there can be a blood test. Maybe there can be a breath test. Maybe there can be a swab that you can do, which is much easier than doing a CT scan, which can detect patients who are at a higher risk of getting lung cancer. So that way you can implement this in a more wider population without having to have that expense and scheduling needed that goes into a CT scan. So it's all happening, and we are part of several of these studies, and it's exciting to see where these would lead.
Absolutely, it's very exciting, and I'm so happy that you're championing all of this. If I could just circle back a bit to the topic of AI for just a moment. Um, So with all the amazing work that you're doing, I think it's a great question to ask a physician like you. What do you think are the pros and cons of using AI as a practicing physician in healthcare? And what do you think the future really holds as it relates to utilizing AI as it, with detecting diseases early as you're doing?
So I think AI has a tremendous potential because of the volumes of work that we need done. So what it has to offer in managing massive patient platforms and keeping tracks of their follow-ups and their reports and any other exams done, I think it's amazing. There it has to be, in addition to artificial intelligence, there has to be human intelligence involved too, because what it does not have is that evaluation that is multidisciplinary, that is involved in evaluating a patient, how to decide a plan, because patients are not just numbers. They somebody who may have a certain risk, even at a high risk, may decide to take a more conservative strategy, whereas there are some patients who may be at a relatively lower or moderate risk, who may meet the criteria to have a more aggressive intervention. So there has to be personalized care, which comes from a combination of AI and human intelligence. So that's where the challenge currently lies. And I think there is a lot that we don't know in terms of potential of AI, and where there could be some fallouts. So there's a lot more to be done than we already know. And I think while there is a tremendous amount of opportunity, there also needs to be some caution. So we are, watching for some fallouts or some issues in case AI were to, I don't know, crash or suddenly turn off or something like that, and we don't completely lose touch of where we need to be. But I think it definitely holds a place in the future, and that's where we are heading.
Wonderful. And something that I really admire about you, one of the many things I admire about you is not only how you embrace innovation, but you embrace empathy for the patient. You embrace the need for interdisciplinary viewpoints on things. And it's just so wonderful. And getting to that point of empathy, I think your focus on this is what really makes you one of the most respected physicians in your field. It's just another one of the amazing qualities that I have, that you have, excuse me, that I really admire from you. And I think it might stem, given that I know you personally, that you're such a creative person. You paint, you dance, you have so many talents. And I'm wondering if you think creativity is an essential element necessary for providers and researchers to tap into these communities to look for better, faster, and more cost efficient ways to improve health outcomes. Are empathy and creative skill sets your secret sauce, if you will, Jasleen?
I'm not sure about that, but I think I agree with you on a certain level, and I certainly tap into that because medicine is a very logical field. We follow everything evidence based. We put ourselves in a box, and we have to follow certain guidelines. And if we are in that box all the time, how do we innovate and envision something which actually doesn't exist at this time? So, and a lot of times, if we just operate in certain limits all the time, it leads to sometimes burnout and not finding that much reward in our careers, as what we may. And that's what I found. So I engage in empathy because it's actually equally rewarding to me as a person, to engage in that kind of interaction with the patient, because that's really the purpose of my life. So I fully engage myself into that. Creativity helps because whether it's sports, whether it's dance, whether it's art, it takes you away from this this realm where you are restricted by boundaries, and you are able to freely think. You are encouraged to think out of the box, to create. And when that kind of stimulus happens in the mind, it's all works globally, and that's how these visions or targets of doing something which right now feels impossible happens. So that definitely works for me, and should be tapped into by a lot of leaders to try to envision things of the future that may right now seem very difficult to achieve, but will be a reality in a few years. I think it definitely helps me keep going on. So I would recommend it.
Wonderful. Jasleen, we are so grateful to have had you on our podcast. We are also inspired by your work, and we wish you every continued success as you pioneer through early detection of lung cancer. So any last words that you may wish to share with our audience?
Well, I would like to say that thank you so much for having me here. It's always a pleasure, and actually, I feel so honored to be, in company of somebody like you, who also being a woman is making career strides on these ends. And thank you for supporting us as physicians. And we appreciate a lot of collaboration that's happening right now within multiple industries. But I am hopeful for the future, and let's keep going.
Absolutely. Once again, thank you so much, Jasleen. We wish you all the best. And to our audience, thank you for listening in. And we look forward to bringing you many more industry thought leaders who are pioneering with innovation to improve your health. Thank you.